Hello, everyone, and thank you for joining us. My name is Ashley McDermott. I'm with the AIUM, and I'll be your host. As part of our continuing education for healthcare professionals, I am pleased to host this webinar, which is a 2024 update to the sonographic evaluation of the brachial plexus and pathologic correlations presented by Dr. Philip Steele. This is a non-CME educational activity in collaboration with Samsung. Today's webinar will identify normal and normal variations of brachial plexus, demonstrate advanced plexus sonography skills, and list common plexus instrument sites. If you have questions for the presenter during this webinar, you may type them into the Q&A box. You will be able to submit questions throughout this webinar, but the presenter will not begin addressing them until he has completed his presentation. This webinar is being recorded, and you will receive a follow-up email within 24 to 48 hours with a link to view the recording. And now I am pleased to present Dr. Philip Steele.
Okay, well, good morning, everyone. This is sort of a labor of love. A lot of people have been bugging me about updating this talk. I get lots of emails, and since this talk was done in 2020 and it got pulled from the AIUM webinar series, I felt compelled to sort of update that. Again, thanks to Samsung, they've been a great supporter for me in many of the workshops I've taught by providing equipment. Our objectives today is really identify normal and pathologic sonoanatomy of the brachial plexus, that variations of the brachial plexus are incredibly common, and that the most common variation is actually what I would call the Netter's brachial plexus that we learned in medical school. But that's just a variation. It's just the most common variation. It's not the only way that these nerves come through this region. And that these variations can mimic thoracic outlet syndrome. And we're going to spend a lot of time kind of on this update looking at the C8 and T1 nerve roots, which will be a little further along in this talk. So plexus scanning skills, it's really important to understand that standard propositions really don't tell the full story. That muscular and nerve tissue is frequently oblique to your proposition, whether you're scanning in long axis or axial. And you need to be moving your probe to sort of follow these nerves as they move through this tissue. Again, the nerves have a lot of variability, and it's the ability to constantly changing your proposition that allows you to understand what's happening, as well as understand what's happening with the scalene musculature. So everyone sort of hopefully kind of remembers some of this. We're going to mostly talk about the roots here, the trunks, and a little bit about the divisions, and then the branches of dorsal scap, long thoracic, and suprascapular nerve. And then at some point I need to do a webinar on the brachial cords, but our focus today is mainly on the supraclavicular portion of the brachial plexus. Now, that being said, the vasculature is always also highly variable. It's interesting that the blood vessels seem to have numerous variations in terms of how they move through this tissue as well. And it's important that you have a good understanding of the transverse cervical and the suprascapular artery. As in this case, you have a transverse cervical going across the top, and this is suprascapular artery going right below the superior trunk. This is C5 and C6. And so there's no way to really approach this from an injection standpoint safely in this region. And so it's important that you always identify these. Although we're not going to spend a ton of time on the vascular component of this, we're mostly going to focus on the nerve component today. Our standard proposition is long axis and short axis, realizing that if your probe is a little too anterior or a little too posterior, the anterior and posterior tubercle may have a slight change in their look, and so you need to be careful to be truly short axis. I do a lot of swiping technique. My fingers are kind of held out of the way, but the whole idea is that you can highlight nerves in the brachial plexus by using swiping technique for this. And this is an example of that. So when you look at a still shot, you have the roots here, but it's really hard to know what's what. Is this tendon? Is this nerve? Is this scaling? What's going on? And by using the swiping technique, you can see that this is the root coming in here, and this is all muscle from the scalenes. And so I use that to help define in long axis what I'm actually looking at, and it can be extremely useful as some of these patients have quite a complicated anatomy. And then I always use sort of a 15-degree angle when I'm looking into the neuroforamen. And that sort of highlights the nerve a little better. If you drew a true axial plane, you don't see the nerve coming out of the neuroforamen quite as well. And then this is an image of C6 and C5, and you have the Chosnick's tubercle and the posterior tubercle here. This is posterior scalene, middle scalene, and then small little nerve roots that we're going to go over throughout the course of this talk. So I like this image to explain why that 15-degree angle seems to help, because these neuroforamen sort of angle downward. And so that really highlights the nerve as it comes through this. And so it's important that you use your probe positioning to make sure that you're not a little too anterior or too far posterior to highlight these nerves, as well as that angle about 15 degrees caudal to help you. I talk a lot about what I call plexus push-ups, and I've taught numerous workshops where people just lay a probe on and take a single image, and then they send me an image, and I'm like, what is this, Dr. Steele? And I'm like, well, I don't know. Can you send me a video clip? And so it's really these video clips of going through this terrain that can be really helpful. So here I'm just sort of scanning up and down. And so what we'll talk about in a minute is how to identify C6, but I typically will go from C6 up to C5 and then back down to 6. I'll do a couple laps. I'll go up to C5 and then all the way through down to C6 and then all the way down to C7 and then back up to C5. By doing this, you're using pattern recognition to help you identify these areas. And so it's really important to do this and get comfortable with doing laps through the area. And then once I kind of have C5, 6, and 7, I'll go all the way down to C8 and then T1 and then back up to C3 and C2. So I'll just go back and forth, back and forth. So the next step before you really dive into the nerves is really understanding the scalenes. And so I'm going to stop this here and I'm going to highlight a few things. So this is anterior scalene. This is a vasculature. Here's a posterior scalene and middle scalene here. And by following the scalene down to its rib attachment on the first rib, you sort of kind of understand what's happening with that portion. And then you need to do the same thing with the middle scalene. So you should always begin your brachial plexus scan by understanding the scalenes and trying to follow them back and forth, up and down, because it's this alignment through this area. This is 5, this is 6, this is 7, this is 8, that helps you to understand the variations that are common in the plexus, because it's the path through these scalenes that creates the variations in the brachial plexus. Now, there's a standard tubercle progression. Bianchi and Martinelli think or sort of suggest that C7 is the best home base. I tend to, numerous other authors sort of use C6. I typically prefer C6 because of it has an enlarged anterior tubercle. This is anterior, this is posterior. And I've never seen a patient that didn't have an enlarged anterior tubercle of C6. Some patients can have an anterior tubercle of C7, although rare. And then C5 is highly variable. The most common presentation is an enlargement of the posterior tubercle, but I use this image just to illustrate the fact that it's highly variable. And so C6 is home base for me. I find Chosnick's tubercle, and then I'll scan up to 5, down to 6, down to 7, back up to 6, up to 5. And I'll do a few laps in here to get an understanding of what I'm actually looking at. This is another example of variability. So here's the C6. This is anterior Chosnick's tubercle. Here's the C6 nerve root. Here's an enlargement of the posterior tubercle. And C7 is on this image is quite shallow and steep. And this is the C7 nerve root. Already you're seeing that 5 and 6 are starting to have little divisions branching between the trunks. And so it's highly variable, and it's important to use the brachial plexus push-ups so that you go, what in the heck is this? And so by scanning back and forth, you get pattern recognition, and you see that there's something wrong with your normal pattern. And this is an accessory SCM that can be identified. And so that up and down plexus push-ups becomes really important, because the more you do it, the more you get comfortable with what normal is, and you can pick up these abnormalities in the muscle tissue, which are quite common. Now, scanning tips for nerves is that anytime you are following a nerve in short axis and you lose it, the nerve switched planes and you're now looking at it in long axis. And so this is an example here of these nerves, the supraclaviculars, and then right here is C5 and 6. And then through all of these planes is these small little branches. This is long thoracic. I'm going to stop this image here to sort of illustrate this. Here we go. So right here is long thoracic nerve. And then as we scan forward, all of a sudden, oops, right there, you sort of lose it as this branch is heading off in a different plane, and then it's just gone. And so what happens is it's now moving sort of toward the posterior shoulder, and the scanning of that becomes difficult. So again, anytime you lose a nerve, just go back to where you found it and then try to follow it again. And so I'll use a lot of laps back and forth to try to find these little small branches that can be really difficult to identify. So here's our classic C6 nerve root and Chosnick tubercle. This is a fairly prominent anterior Chosnick's tubercle. This is a wide set, deep neuroforamen, and I try to describe them. Some of them will have be shallow, some of them are narrow, some of them are quite wide. And so the wider they are, the less likely you're going to have an entrapment. The more steep and narrow they are, the more that they can create some impingement or entrapment findings. Now, so anterior tubercle, here's posterior tubercle. You see some posterior scaling, middle scaling. These are the fascial planes that we're going to talk a lot about in this talk. This is C5, and then over up here is C4. So usually when you're scanning down the plexus, C4 should be on top of C5, which forms the supraclavicular nerves. This is actually phrenic nerve, and phrenic nerve can come off of 4, 3, or 5. And if you're doing injections in the brachial plexus, you want to be able to identify this on a regular basis. We're not going to spend a ton of time on that today, but that is an important aspect of your scanning protocol if you're going to do procedures. So C8 and T1, when I gave this talk in 2020, I didn't really have a good way of seeing T1, and you could find it in maybe about 80% of the time you could see the C8, and T1 was really difficult to identify. And so we're going to go over kind of some new ways to look at this, and I've spent a lot of time trying to show how these nerves can create entrapment for thoracic outlet. But obviously, the patient with that short, thick, wide muscular neck can be challenging. Most of the time you can see C8, but T1 is the challenge, and because the inferior trunk is commonly entrapped in the brachial plexus. You can see in the scan here that this person has a significant variation in terms of how C5 joins up with C6 and the anterior middle scaling, which we're going to go over here as we move through this talk. So here we have C8 that is, C4 and C3. And C4, you can see coming out. I'm just doing little push-ups. And the typical anatomy of C4 is typically an enlarged posterior tubercle, or they're kind of neutral. And so this is C4 coming up. That forms supraclavicular. And C3 is here, again, a slightly enlarged posterior tubercle. And it forms mainly greater auricular and transverse cervical, which is part of the advanced workshop that I need to update as well. And so this is the challenge in this area is you need to learn to look at these because there's this thing called a prefix C4. And prefix C4 is an important finding because it changes the radicular pain pattern from a C5 injury. And so this is C4. I'm going to stop this and I'm going to go all the way back. There's C4. Here's the posterior typical, anterior scaling, posterior scaling, and middle scaling, and SCM vasculature. And as we come up, you can see the nerve root heading out. And it's interesting in that you'll see immediately it splits into two pieces, which is not typical. And as it splits, you'll see one that stays here, and this one forms supraclavicular nerve. And so as we go back, you can see this is all supraclavicular. Now you're going to watch as we're going to do this again, and you're going to see this is C5, this is C6. This C4 joins C5, C4 joins C5, and that's called a prefixed brachial plexus. So you have a C4 contribution to your C5 component, and that can dramatically change radicular pain patterns. And these are actually not super common, but I see them if you start looking for them. This is another example of the same sort of pathology. We have SCM, we have a greater auricular nerve here, supraclavicular, and the C4 contribution to C5 as part of the fixed lesion. And so here we have, this is right here is C4. And as we scan up, you'll see it divided into two pieces. And C5 is going to come up right here. This is C5. This is going to be supraclavicular heading posterior anterior vasculature. And you're going to see it join up with the C5 component. And this is important to document because it changes, again, the radicular pain pattern that can occur from like a C5 or C4 disc herniation. Okay. So now that we've kind of talked about the prefix lesion, we're going to talk a little bit about the size of the nerve roots as they exit. This is a massively enlarged C6 from a Parsons-Turner syndrome. But normal nerve anatomy, you see monofascicular hypoechoic, and they typically have a normal size to them. There's multiple studies out there collaborating this, or correlations are quite common. But from my world, I always think of C5 as 6 to 8 millimeters, C6 is 8 to 10, C7 is 10 to 12, and C8 starts to go back down. And it usually is about, if this is 12, this is about 2 millimeters less. So if this is 11, and this one should be 9. And so that's typical arrangement. The root sizes do increase from C5 to C7 and then decrease from C8 to T1. So T1 is smaller than C8. As a general rule, if you see something less than 12 millimeters, it's probably okay. If it's greater than 14, you really should look at the contralateral side. And I'm a strong advocate of before someone has a cervical fusion, we should probably be scanning their nerve root sizes so that we can see if there's a complication from the surgery. Okay, scanning the roots is a lot of it's just if you do enough brachial plexus push-ups, you know immediately that this is wrong. It should look like a snowman. The C5 should be smaller, middle size for the C6, and the biggest at C7. And so when you look at them and you see C7 and C6 are about the same size, you know something's is abnormal. And again, you can always check with the contralateral side to confirm. So if the nerve root's enlarged, that's really helpful, but the nerve can be injured in other areas. And so signs of fascicular injury is loss of normal nerve structure, increasing diameter of the nerve, a deformation or what I call cap sign or comma sign. And you can see that right here in terms of the nerve coming out here. And so what's happening here, here's C5. and it's heading up and over as you scan downward, and it goes over Chosnick's tubercle right here. This is Chosnick's tubercle, and you can see the nerve right here has sort of like a little cap. It looks abnormal here. And so it can be difficult to see these in some patients, but these little small comma or cap signs can help you identify areas of abnormality. So the normal scaling concept is really of C3 through C6. Here on the anterior portion is the most common sort of description. 2 through 7 and C4 through C6 is the most common variations as described in the literature, but in reality, it can be quite different than that. So here's our anatomy apps that you have on your phone or your iPad, and this muscle looks quite small and petite, and that's not reality. It can be quite big and beefy. We're not going to get into longus coli and longus capitis, but those muscles are there anteriorly. So based on a cadaver study of 10 dissections, we had 20% had on this series of 10 cadavers, only 20% had the sort of traditional 3 through 6. 30% had 3 through 7, and only 50% had a C3 attachment. So it can be quite variable in terms of this. And so the more attachments you have, the bigger the muscle. And so in some individuals, when they have a 3 through 7, you'll see quite a large anterior scaling. And in other individuals where you have just a 2 attachment, like a C4, C5, the muscle's quite petite and doesn't seem to entangle the nerves as much. Now, the posterior tendon or posterior attachment to the tubercle is middle scaling is typically thought to be 2 through 7, and posterior scaling is 4 through 6. And levator scap also 1 through 4, which is more advanced concept that we'll talk about in the next update. But it's important to realize that only 60% had this normal anatomy, and 40% have some variability. And in their 10 cadaver study, 50% had a C1 attachment, which isn't that well known, but frequently can cause problems. So it's important to understand these muscle attachments are highly variable. Posterior scaling's a little simpler. There's either 50% have C4, 5, and 6, and the other group have 5 and 6 as their common anatomy. And then levator scap also has lots of variability. Only 60% had 4 slips. What's interesting is the levator scap, if you search the literature, there's lots of variations. So accessory attachments to the occiput, mastoid, ribs 1 and 2, trapezius muscle, and then even the scalenes can be part of their attachment. So when you're seeing someone with chronic levator scapular pain, you need to search for that these other anomalous attachments. And then finally, in terms of the scalings, you'll see in some individuals the inferior trunk or C8 and T1 is completely surrounded by muscle. And that's typically from what's called a scalene minimus. And so here's the normal triangle here, the anterior middle scalene triangle. Here's middle scalene, here's anterior. But this comes through and and surrounds the C8 and T1 nerve root that form the inferior trunk. And so these can be seen. They're a little challenging to identify, but can be seen. To really look at C8T1, I sort of had to develop a new way of looking at the neck. And this is how I'm looking under the clavicle to really see this. And so in some individuals where they have a fairly short neck, to see T1, you have to be fairly inferiorly angulated. And that's going to vary on different people. A lot of people are just right here. You can see T1. Others, you can see it here. And some people, you have to get way underneath there to see that T1 nerve root. And so this is an example of that. And this is T1 right here, and this is C8. Now, I'm using a technique that I developed to help understand this area. So what I do is when I get the right angle, I can see the nerve right here. What I'll do is I'll subtly push deep into the skin here, and then the nerve will sort of slide out and become better visualized. And so you can practice this. It's just a subtle little push. I'm pushing deep into the tissue. It's not a hard push, it's just a subtle push. And if somebody has thoracic outlet, they'll get sonographic Tunnel sign, so they'll get tingling in their hand and arm if this is entrapped or part of the problem. Now, this is the area that's sort of the new to this update. So what's important in looking below the clavicle is understanding the anatomy. And so you've done your scaling push-up. This is middle scaling here. This is anterior scaling. And that's the plexus, and anterior scaling's over here. This is middle. And people send me slides and say, what is this? Well, this is all serratus anterior, and serratus anterior in many individuals sort of fits on the anterior portion of that first rib, and the scaling sort of attaches to the deeper posterior portion of the rib. And that's why in some individuals that there's actually scaling, and there's a serratus anterior can entrap the brachial plexus here. So be aware that this is here. Surprisingly, this is middle scaling, so you're seeing first rib. It attaches fairly far posterior on the scaling. You can see the middle scaling attaches fairly far posterior, and that serratus anterior comes up and over in front. In some individuals, you won't even see the middle scaling. You see all anterior scaling all the way over here to the interval. And so those are actually common. And so again, the scaling push-ups are important. This is an interesting case that I saw recently. And here you have, this is C6, a very abnormal looking weird C6. This is C5 coming out right here. This is C5. And we're going to go C6 and 7. And look how elongated the nerves are through this tissue plane. And this has a very interesting C7. And you can see this is C7. You look at the anterior tubercle here, and posterior tubercle looks quite variable. And then this is C8. And then you can see T1 right here popping out. And so that forms the inferior trunk. Okay. So we've talked a little bit about looking at 7 and 8, and then the plexus variations are most common at C5 and C6. Kerr back in 1895 to 1910 cataloged almost 30 different variations. He came up with a 53.5% of his cases showed a significant plexus variation. So the normal anatomy that we're taught is just the most common variation. Numerous cadaver studies have also confirmed that these variations are high, and that more than 50 have been described in the literature. This is from an older Martinelli paper, but there's a wide range of these variations. So accessory scaling seen in about 25%. I see a narrow constricted interval, which can cause a significant entrapment of the nerves. And then we'll go over a couple basic variations as we move through this lecture. So an accessory scaling does not attach to the tubercles, and it's from the anterior to middle scaling. So this is an example of that. And so you can see this muscle slip going from middle to anterior. Right here's anterior right here. And the slip is dividing C5 and 6 and C7, and what's going to eventually be 8. The width, the position of this can cause nerve entrapment. And in some cases, they're quite close to the neural foramen as the nerve exits out. And when it does that, it can trap the nerve. So this is sort of my drawing of that. This is as a variation of the brachial plexus with C5 goes all the way around anterior scaling. This is C6. This is an accessory scaling between 6 and 7. And if this is low down here and comes out over the top, or it's a bigger variation, it can entrap the C7 nerve root as it comes out. So this is our tendon slips of the scalenes. And here's middle. And the dorsal scapular nerve typically runs through the interval between the C3, C4 slip, that's right here, and the C5 slip. So this is where dorsal scap comes. And usually the 5 contribution, the C5 contribution for long thoracic nerve comes through that same area. And then 6 can come through a different area or through that same interval. And we'll go over that here in a few minutes. So this is an example of a narrowed scaling. You almost can't even see the brachial plexus here. So here's them after they formed, but acoustic shadowing and how narrow this interval is completely hidden those nerve roots as they come through. So and it's sometimes you're seeing this in weightlifters and power lifters and people that do construction. And then sometimes it's in a female with a narrowed interval with no real history that would suggest hypertrophy of these muscles. So, again, when you see a large accessory anterior scaling or middle scaling, it may be because they have multiple slips versus just a wider insertion onto the first rib. This is a drawing. I didn't draw in the 4 and 5 contribution to anterior scaling because I wanted to highlight that the nerve coming out of 5 comes underneath, and then it's going to roll back into its normal anterior middle scaling interval. And when it does that, it can cause entrapment or compression of this. And so this is an example of that. So this is C5 right here. This is C6 right here. And you can see C5 is going through, this is anterior scaling right here. That's a blood vessel above there, but it joins up. Actually, that's a prefixed lesion, sorry. And there it comes through and around. And so it comes all the way around and through. And so that's this 13% variation. So it's been found in pretty numerous cadaver studies ranging about 10 to 15% of the time. And you can see the deformation of the nerve and the cap sign that we talk about creating tension within the nerve. And when you sonographic assisted palpation of this nerve frequently will give someone a Tinel sign. This is what's called, I call around the world. Again, here's C6. This is C5. And here's 5 coming out of the neural frame. And you can see the enlarged posterior tubercle. It doesn't have much of an anterior tubercle on this individual, but it's going to come around. And you can see there's quite a bit of deformation of the nerve as it slides up and over. So look how under tension this is to lie in its normal anterior middle scaling interval at this location. So this is kind of how it slides around. And again, Tinel sign or sonographic palpation. This is another example of something similar. This is a very narrow band of the anterior scaling. And the nerve is just sliding up and over that right here, right there. It's going up and around. And I'm just highlighting this narrow slip that it goes through to lie in its normal scaling. So rotation of the neck, side bend of the neck may increase tension and some C5 radicular symptoms to the shoulder. These variations are quite common. In this example, you have a central tendon. It's a very large central tendon here. This is C5. And you can see the nerve is right here. It's sort of not quite true round. It's a little oblique in its position, but because it's coming around, but it's under a lot of tension. And if you do, again, sonographic assisted palpation of the nerve at that location, you may get a Tinel sign. And so that's a pathognomonic. And so this is these different variations that can be identified. Okay, in this variation, we're going to look at, this is C5, this is Chosnick's tubercle right here, this is C6, and we're scanning down, scanning back up. So here's C6, C5, sorry, C5, posterior tubercle, anterior tubercle. We're gonna scan up, and then as you're, as we're scanning down, you're going up and over the Chosnick's tubercle, and the nerve is compressed as it goes around there. And so if you compress and push on this nerve with sonographic assisted palpation, you may reproduce the patient's symptoms at that location. Occasionally, you'll see an enlarged posterior tubercle. This is C5, 6, and 7. realize that the long thoracic nerve branch from 7 has to come up and over and around all of this deformed tissue. C6 is the more common injury here, as the long thoracic nerve is heading to this location over here, and it can be compressed with these enlarged tubercles. So rotation of the neck, and if you push down on this area, you may have some scapular type symptoms. So here we are. You've seen this image again or before. Chastonix tubercle, posterior tubercle, C6, C5. And what you're seeing here is this is mostly posterior scaling, and this is middle scaling. And you can see middle scaling goes all the way across and inserts on the wrong side. And so this is called an anomalous slip. And they're more common than you would think. You just have to be aware that they exist. So when you see a muscle band going across and through the neural frame, and it's typically anomalous slip. Remember, an accessory scaling will not attach to the tubercles, and so this is essentially what you're seeing here in this image. And then this is again an interesting where C5 and C6. So this is C6 and that's C5. It's not a great image, but what we're going to see is 5 and 6 forming up here, and they're going to go through and around. Both of them go around the central tendon of anterior scaling. And so that part is important to identify, because anytime they rotate their neck, they're going to get, or sideman their neck, they may get a radicular pain pattern, and it can be quite significant. And then this is an example of kind of a middle scaling entrapment, suspicious for possible scaling minimus. You can see a muscle all the way around. It's a little deceiving because there's a blood vessel right here. I'll stop that. Right there is the supraclavicular artery, but there's muscle surrounding this in a lot of this scan. And then you can see everybody heading posterior as part of this study. But anytime you see muscle surrounding, be suspicious. Now, I kind of mentioned that the serratus anterior can cause some entrapment because it creates a very narrowed window. So this is T1, this is C8. Look how far over serratus anterior is. There's no opening in here for these nerve roots to exit through. So it's quite narrowed. You can see SCM is on this earlier image. And then as we scan through, you'll see this right here. That's omohyoid and serratus anterior. So we're right down low to the clavicle, and we're looking at the first rib here. This is pleura of the lung. Okay, now the fibrous bands that I want to spend a little time on. In this example, you can see this is going to become the inferior trunk, middle trunk, superior trunk. This is a piece of the middle scaling, but more importantly is that the nerves come through there. You see them roll around something. And so what that hyperechoic structure is typically a fibrous muscular band. And this band is coming straight at you looking at this image. So it's hard to visualize because it's not, you're looking just at a piece of it, the edge of it, not at the length of it. And they're a little hard to visualize in some people, but they're usually hyperechoic, and you'll see the nerve wrap around them. And these fiber muscular band can create a snapping sensation with rotation of the neck. And with sonographic, if you palpate this right here, you can create some radicular pain pattern, more of an ulnar nerve sort of distribution. So here's another example of this sort of situation. So this is called a wedge sickle sign. And this is the fibromuscular band right here that the nerve's wrapping around. So this is this T1, this is C8. And this band is coming straight down towards you. That's the best way I can describe this. But this is called a wedge sickle sign. And right here you can see this is T1, this is C8. We're going to go back. And you can see here, this patient has a cervical rib right there, but there's a fibromuscular band from the end of that cervical rib that's creating entrapment here. And that entrapment can create a radicular pain pattern. Now, these typically present like a thoracic outlet syndrome. So Roos, clear back in 1979, described a bunch of these bands and 14 different band configurations he described in cadavers. And he really felt like these fibromuscular bands were the real culprit in neurogenic thoracic outlet. And so there's been several papers out there looking at these fibromuscular bands. And this paper was some surgeons that do thoracic outlet surgery looking with ultrasound. And then they described how that this wedge sickle sign is almost pathognomonic for neurogenic thoracic outlet. So what they found in their study, and they did surgical releases of these, at 95% sensitivity to neurogenic thoracic outlet if you saw a wedge sickle sign, and 85% positive predictive value for thoracic outlet. And then if you have Tinel's sign with the sonographic evaluation along with the wedge sickle sign, it had a positive predictive value of 100% for neurogenic thoracic outlet. So that's a really important way to evaluate patients for neurogenic thoracic outlet. There's multiple other factors: the shape of the bone, how the bone, the edges of the bone, and how the nerves come over them. But again, the wedge sickle sign is the most obvious, easy way to describe a neurogenic thoracic outlet. So there's lots of different bands. I'm not going to go into it. There's type 1s, type 2. There's 14 different type bands. You can dig into that with some of Russ's papers. But here you're seeing a wedge sickle sign, an enlargement of C8 nerve root. I mean, the T1 nerve root, and C8 is just above it. And you can see this deformation of the nerve. You can see how it just sort of wraps around that in a wedge sickle sign, pathognomonic for a neurogenic thoracic outlet. Now, this is from a PT colleague of mine who teaches some of this work in terms of these fibromuscular bands actually in some patients attach to the dome of the diaphragm, the pleural dome here. And so some of these you can see occasionally seem to go down to the pleura. And so that I've seen in a few occasions. This is a fibromuscular band right here, and I'm sort of questioning what this is coming down here to the dome of the diaphragm. And so these are all things that have been described in the literature and can be identified on ultrasound. So again, visualizing that area deep to the underneath the clavicle becomes really important. This is an example of using that my subtle push to highlight the T1 nerve root. So this is the T1 coming out right here and joining up with a C8 to form the inferior trunk. And then this is after I hydrodissected someone with neurogenic thoracic outlet. We did a release, tried to get rid of this fibromuscular band and get fluid flow around it. Sort of helps highlight the superior, middle, and inferior trunk. And then just a side note for people that are doing a lot of thoracic outlet evaluation, I typically do a compression test. I'll get my ultrasound lined up on the nerves, and I'm looking at what happens to these nerves. You can see this huge S-shaped curve underneath this area. This is subscapularis, this is inferior, this is superior, this is the scalenes coming through. And you can be surprised. Sometimes I'll see the nerve even snaps or pops through this when I perform this compression testing. And then finally, there's a fair amount of variability of the superior trunk. And this is an example that's kind of odd. Let's see, where's the best? Here we go. So this is superior trunk right here. And you can see the superior trunk. This is supraclavicular. I mean, not supraclavicular, subscapularis. And then this is a part of that superior trunk. And here we go. And this part of the trunk divides into two pieces. So this portion of the superior trunk has a medial division and a lateral division, as well as a suprascapular nerve. And so these can be identified, and they'll have a rare radicular pain pattern. Now, finally, we're kind of dive into just the dorsal scapulon and suprascapular nerves. Again, you want to identify fascial planes. It's important that you look for the fascial planes for these little nerves. And so this is an example of a nerve coming off a C5 that we'll kind of talk about here. And you can see this fascial plane. You have 3 little hypoechoic dots that represent different nerve structures. Okay, again, this is this crude drawing I have, but the nerves are going to travel through these fascial planes. And the easiest ones to identify are 5 and 6. 7 can be problematic because it's quite deep, but you can identify them. But again, here you see this fascial plane and everybody hanging out right here, which we'll show in the long thoracic nerve study. Here's 5 contribution here. So I'll show that again. So this is all long thoracic nerve. And then you see somebody leave late. And I'll talk about this in a minute. So once they all join, when it leaves late, that's the long thoracic nerve to the first serratus anterior off the first rib. And then this is going to head down to form the C6 and C7 contribution. That is not dorsal scapular nerve, okay? And we'll show that in a minute. Okay, so you need to understand the anatomy. At C5 typically innervates just the serratus anterior to the first rib. C6 innervates 2, 3, and 4. And then all of the rest of the serratus anterior comes from C7 as a general rule. Now, there's a lot of variations to that, but this is a general rule. So a C7 abnormality will cause inferior angle winging, where an injury to the C6 contribution will create injury to and medial border elevation, and then this is superior angle winging when the first branch off of C5 is injured. So this is kind of how I look. First of all, I want to be sort of perpendicular to these fascial planes. So you want to change your probe angle so that you're looking into these areas so that you can highlight them. And here you'll see that there's a nerve right here waiting for this one. Okay, that's long thoracic right here. And that's the C5 contribution waiting for that. And we're going to follow this one all the way back into C6. So here is C6, and then it joins up. And we're going to show some more examples of that. But C6 is the easiest one to find, goes all the way right in, right here, comes in at the 10 o'clock position. Okay. Now on this example, went too fast. On this example, we're going to follow these nerves. Oh, sorry. Oh, still not going. Okay. So this is not letting me work this one very well, but you can see that one nerve's waiting for the other. That's classic for the long thoracic. And then there it comes into 6 right there. And then there's the branch coming into 5. I'm not sure why the video clip's not working here well, but you can see them join together, 5 and 6, 6 and 5 back together. And then right here, you'll see there's a subtle nerve right in here that heads posterior, which is the dorsal scapular nerve. Sometimes these nerves have a very serendipitous route through here. This is an example of right here. I'm going to stop this clip. You can see right here something rolling over a central tendon of middle scalene, and that's the nerve right here going up and over. So this person has some medial border scapular winging, and the nerve is injured at that location. It's swollen and abnormal. It's under tension. And so following these paths can be a little challenging in that sometimes they wind their way through the scalene slip, so they can come under and over and into different areas. Again, the long thoracic nerve has some variability to it. The most common presentation is about 38% of individuals have a C5, 6, and 7 contribution, but there's certainly other variations that have been published. Certainly just even a 2 C5 and C6 variation, and 6 and 7, although I've not seen that. But these are all been described. And again, variability is the rule. And we talked about when you bring long thoracic together from 5 and 6, and 7 usually joins up, if you see something leave late, that's usually the posterior branch to the serratus anterior, or the R1 branch is what I call it. And this R1 branch will create a superior angle winging because the serratus anterior, when you look at the serratus anterior, if you go to my scapular dyskinesis talk, we talk about how to evaluate the serratus anterior. But the serratus anterior here is atrophied compared to this side. And so you're going to want to be able to look for that R1 branch here to scan for and see if there's an abnormality to that. So if the nerve heads to the serratus anterior, that's the R1 branch. If it heads to levator scap, then it's the dorsal scapular nerve. And this is a nerve hydrodissection, and it just shows how interesting and sort of serendipitous these nerves come through. It sort of winds through all this tissue plane to get to its correct path. So you can see the nerve right here. This is long thoracic. And you can see how it just sort of winds through this tissue plane to get back together. Okay. Dorsal scap's the more complicated of this because it's highly variable. It has lots of different positions, but this is a great example here of what's called a common trunk. And so right here, you can see this is the 6 contribution. This is the 5, and 2 nerves joined together. And so I've not seen when they join together like that, that's usually called a common trunk. See how, I'll stop that again. So as they come together, they form together, and then you'll see a third guy come in right here. Now this, if you follow it, it takes off and goes over the top of the middle scalene and heads to levator scap. So that's dorsal scapular nerve. And if it waits, it's going to wait for the long thoracic nerve from 6. So there's the 6 component going back and forth. And you can see here, these two join up together right here, and they form into the C5 at 11 o'clock. And I use that a lot in my dictations so that I can find the nerve again. Again, the dorsal scapular nerve has many variations. It can go through middle scalene. It can go up and over C4 slip. It can go under C5 slip. It can have a common trunk. It can go around anterior scalene if they have a typical variation. And sort of can kind of go up and over and through. This is a nerve hydrodissection of the dorsal scapular nerve that was entrapped in a middle scalene. This image here I have on C5 and then angled towards the scapula to see this long axis of view of the dorsal scapular nerve. But again, understand the long thoracic nerve before you dive into the dorsal scap. And so again, you can sort of identify these coming off early. Dorsal scap tends to come off early if it comes off by itself. And so right after it exits the neural foramen is the easiest time to identify that. And then again, it's highly variable. There's lots of different paths. So here's a fascial plane here and a fascial plane here. And so you have long thoracics coming this way, dorsal scaps coming this way. And so there's a lot of variability into this. And again, in cadaver studies, it's only 70% of the time does it come off a C5 in this one cadaver study. And then 30% had a common trunk. 30% almost had a C4 variation. So it can be quite variable. So it can be challenging to identify the dorsal scap. Anytime you can't find it, start thinking about, is there a variation I need to scan for? And then finally, kind of the last thing is suprascapular nerve. An omohyoid here, it always lives under omohyoid. This is superior trunk right here. And there is this nerve that comes off the superior trunk. So the easiest way to find that is find where 5 and 6 join together, and that forms the superior trunk. And the first branch that heads posterior is the suprascapular nerve. And so that's an important tip-off to that. And so again, always find 5 and 6, bring them together, and the first branch off. Occasionally you see entrapment as you head posteriorly. If the nerve is entrapped in the suprascapular notch, or it's caught up in some fascial constrictions, you'll see enlargement of the nerve. And so these can be opened up. This is omohyoid above it. This is a rib underneath that area in serratus anterior. And then finally, on this example, sometimes the suprascapular nerve goes through the muscle. And so this is superior trunk right here. And you can see the nerve right here. This in the long axis is going through middle and posterior scalene, which can entrap it and cause chronic shoulder symptoms. So here's superior trunk. And the first branch off is right here, heading posteriorly. And then finally, just the brachial plexus sheath. I realize if they have, not everyone has a plexus sheath that's obvious, but if you do injections into a plexus sheath and you see a nice hyperechoic rounded structure surrounding the fascia, do not put more than 30 cc's of fluid into that, as it can be associated with injury to the nerves. And then this is an example of the nerve getting hung up as it exits out of the fascial sheath. So superior. Okay, so that's all I have. I know that's a lot. I'll take some time for some questions. The relationship between radicular pain patterns and the anatomic variation is very interesting. Are there any prospective studies or large correlational studies on brachial plexus anatomy and pain mapping? The problem is that many of these patients come to me from all over the country, and so a lot of this is clinical observations, and from my perspective, there isn't a good study that I'm aware of looking at correlations between these variations in the plexus and pain mapping, because I'd have to actually inject each one of these individual variations and then map them up in particular. And there's a few articles out there about these variations, but no one has done a clinical study, and that would be an interesting a study to perform. But you'd have to have a practice that's primarily focused on brachial plexus issues. When doing costoclavicular compression maneuvers, I expect that some deformation will occur even in asymptomatic patients. How do you determine how much compression to you is too much? I don't, a lot of people, when I'm doing that, it's a subtle compression. It's not very hard. And again, if they have a wedge sickle sign and you just have light pressure over the nerve when they have a wedge sickle sign, just the ultrasound portion of it gives them a Tinel. If you're doing the subtle compression, it's less specific. But I think most of my patients say, when I'm scanning them, say, well, my hand's going numb while you're doing that. And so that's, I think, the more classic description. But I certainly use my finger a lot to press on the nerves. And you could put your finger on lightly on a lot of nerves and they won't get a Tinel's, but if it's irritated, they will. Let's see. In what clinical scenarios are you performing hydrodissection? If I see an entrapped nerve with deformation of the nerve, it's enlarged, I'll release them frequently, and especially if they're getting radicular pain for them. I see a lot of people that have been diagnosed with thoracic outlet, and somebody's wanting to remove a rib, and then somehow they make their way to me, and then we try to um, solve this without a major surgical procedure. What are you using for hydrodissection? I typically use mostly just a D5W and a very low amount of lidocaine. So like 0.1% lidocaine. That way, if I touch the nerve, there's a little bit of anesthetic quality to it. I do a lot of this. Like just yesterday, I think I released 3 brachial plexuses. Again, you gotta, if you're gonna hydrodissect this area, you really have to know the vascular anatomy very, very well. And to get down at C8 and T1, you have to have really high level of skill to do that area, because you can give somebody a pneumothorax quite easily. You can see how close you are to the pleura of the lung. But what's important is that you identify these and then start working at releasing C5 and C6 abnormalities, and then work your way to dorsal scap or long thoracic nerve abnormalities. And then as you develop more and more confidence and more skill level, start working towards C8 and the inferior trunk, and then to release an approach that T1 nerve, you need to have a pretty high skill set to do that. So that's all the questions, I think.
And we'll conclude today's webinar. Thank you, Dr. Steele, for a great presentation. Thanks to all of you for joining us, and I'd like to thank Samsung for partnering to make this webinar possible. As a reminder, you will receive an email within 24 to 48 hours with a link to review the recording, and this will also be posted on the AIUM website. Lastly, when leaving this webinar, we would like for you to go back to the AIUM webinar activity where you can take a brief survey. We would appreciate any feedback you could provide. We will use that to help us plan our future educational offerings. And with that being said, we'll close out the webinar. Thank you again for joining us and have a great rest of your day.